the quality of life in type 2 diabetes management. I want to introduce first the chairs of this session, that is our first panelist is Professor Dr. Mujtaba Hassan. He is the consultant endocrinologist. I want to invite him to please come on the stage to have a seat, sir. Our second panelist is respected Dr. Asma Khan. She is a diabetologist and Vice President PCDA. Ma'am, you should come to the stage and have a seat. Now, I want to introduce an amazing personality, a well-renowned endocrinologist at Shifa International. He had got a wide experience regarding the diabetes and diabetes technology management. Consultant Dr. Umar Yousuf Raja to come on the stage to have a presentation, and have a big applause for the sir.
Thank you, Fahim, for the kind introduction. Thank you, Getz, for inviting me to present on this quite important topic, and thank you, PES. I knew it's an early start, but I think this is quite important because you've heard a lot of talks about the diabetes complications and why we should treat diabetes. But equally important is what diabetes matters to the patient, how it will improve by treating diabetes, their quality of life, what quality of life is, and how quality of life can impact not only the people with diabetes, but also their families as well. So now we all knew that diabetes affects life of person who have been diagnosed with diabetes. So if you just tell someone who you see in your clinic that you have got diabetes, it will affect their quality of life. It will deteriorate their quality of life. And of course, if their diabetes is present with other comorbidities, that quality of life is very much deteriorated. But then we all say quality of life. What does it exactly mean? Is it just the absence of sickness in a man's life? Is it something more? Can we measure it? How can we measure it? So let's just delve into that. And then once I've described about the quality of life, I think we need to think, do we have quality of life studies in Pakistan as well? So here you can see the quality of life. It's a unique concept. It's quite important because it's an important goal for the treatment in chronic illness. And hereditary quality of life is defined as a subjective assessment of impact of disease and its treatment across broad domain of physical, psychological, and social, of functioning and well-being. And the quality of life studies require evaluation of various life dimensions and have an impact of different treatment. So because with quality of life, not only they have the treatment importance, but also they have got significance regarding policy, preventive, as well as individual. So for example, NICE, the National Institute of Clinical Excellence, their criteria for approving any medication is that it should fall below 20,000 quality of life yearly adjusted. So that's a policy impact. And of course, the newer medications or however way you are treating the life, one of the important measure is what we call as PROMs, patient-rated outcome and measures. And that's very much depending upon the questionnaires of the patient about how a particular treatment affect their quality of life. And that's across diabetes, rheumatoid arthritis, and other chronic illnesses. So all of you most probably know that diabetes have significant effect on quality of life. So, and these are the domains, not only the physical health, but also the social aspect, psychological aspect, cognitive, mental health. And as in people with diabetes, the number of medications or the newer treatment options increase over the course of time, the quality of life of diabetic patient deteriorates. So here you can see, I mean, this is a study from diabetic medicine. So 62% of a patient with diabetes report reduced physical health. 46% reduce emotional well-being. 44% think that diabetes have a negative effect on their finances. 38% on real activities. 35% on work and studies, and 21% relationship with family and friends. And there you can see across these studies, so this is the proportion of people with diabetes who have significant emotional distress. And across countries, you're looking at around about 40% deterioration in the quality of life in people living with diabetes. And then certain countries, so I think we are very much near India, where this deterioration in quality of life or emotional distress in people with diabetes is around 50%. So I think in our part of countries, this is much higher even than those, the Western countries. What about the family? So here you can see that 40% of the family of people living with diabetes express high level of distress related to concern about their relative with diabetes, and 35% reported a moderate to very large burden from caring for a relative with diabetes. And of course, I think diabetes is a disease that impacts families. It can have an impact on how families cook, how it can affect their finances. So I think that's a big chunk. But despite that, 71% of family members have not participated in any diabetic education in type 1 diabetes, and 77% in type 2 diabetes. And it's an important goal of care as well. So this is an ADA goal of care, and there are only two goals of care when you look at the ADA guidelines, ADA and ESD. Firstly, to prevent complication, but secondly, to optimize quality of life as well. So that's why I think the treatment for a person with diabetes not only cut across the reduction of physical complications and symptoms, but also through improving their quality of life as well. And here you can see the comprehensive medical evaluation assessment of comorbidities. You all know about that better than me. Diabetes history, family history, personal history. But look here as about behavior factors, social life assessment. These are the important part of comprehensive assessment in a person living with diabetes, not only as a baseline, but during our annual follow-up check as well. So how do we measure head-weighted quality of life? So here you can see the generic version, but with diabetes, there are diabetes-specific head-weighted quality of life as well. So global, like diabetes-rated well-being, the broad diabetes merited domain, like physical, psychological, socioeconomic, and also then individual component, which are quite specific to diabetes. For example, the insulin management burden, regime distress, the cost of insulin, the cost of other medications. So how can we measure it? I think this is a busy slide, but this is quite important because here you can see different scales. So for example, paid problem area in diabetes is a 20-item questionnaire. Diabetes distress scale, I'm going to come later on. It's a 17-item scale. There's a specific one related to type 1. So this is type 1 diabetes distress scale. It's a 28-item agenda. Well-being questionnaire 28. It's a diabetes well-being. There's a subscale in that about diabetes well-being. It's a 12-item agenda. Diabetes specific quality of life. I'm going to come to that as well. And then there's an illness perception questionnaire, which is a 6-item agenda. So there are different questionnaires by which you can actually measure different aspects of the quality of life of people living with diabetes. A few words about diabetes distress scale. So this was first proposed in 1995 by a group of psychologists from Joslin Center. And actually it is recognized as a distress resulting from burden and demands of diabetes management, challenges of interacting with HCP, and stress placed upon interpersonal relationship. So here you can see there are 4 themes: emotion-related distress, physician-related distress, regime-related distress, and then interpersonal distress. And these are people who don't have what you can say as per anxiety or depression. These are people who are just living normally with their diabetes, and they might be fearful of seeing their physician, or they are having quite complicated interpersonal family dynamics, or emotion rated distress. So with those sort of basically questionnaire, you can either have a mean score of less than 2, which indicate little or no distress, or between 2 to 2.9, which is a moderate distress, or more than 3, which is a higher distress. And the diabetes, you can estimate that 1 in 5 with type 2 diabetes and 1 in 4 with type 1 diabetes has high levels of distress. And down to study shows 45% of people with diabetes shows diabetes stress. And here again, maybe another idea for a study. I am not aware, and I think the panelists or other people in the audience can inform me if there's any diabetes-registered distress studies in Pakistan. So I think this is also a domain where we can have a lot of studies if someone is interested in exploring that issue. What I'm interested in is about diabetes quality of life questionnaire. So here you can see it's a 13-item agenda. 6 rated to satisfaction, so time taken to manage diabetes, time spent getting checkups, time it takes to determine sugar level, current treatment, knowledge about diabetes, and life in general. 4 rated to the impact, so feeling of pain associated with treatment, physical feeling of illness, interfere with family life, and limiting social relationship. 3 with the worry, so passing out, getting complication, body look different. So each item is ranges from 1 to 5. 5 mean higher, poor quality of life. So total there is a 65 points. Higher the points, worse the quality of life. And there are studies which shows that if you improve quality of life by interventions such as self-management, education, the HbA1c reduced by 0.8%. What about Pakistan? I think that's quite important. Do we have any quality of life questionnaires? So GATS did launch a digital tool for quality of life, and I will delve on that for maybe a couple of minutes, because you can take your mobile and you can take a picture of that, where you will have a quality of life on your mobile app. And it's quite important and quite simple how to measure quality of life in your clinic, because all you need to do is, while your patients are waiting, you can just give them questionnaire to fill it up, translate it in Urdu, and you will have a very, very good ideas of how your person or people or your patient with diabetes are living, and what are their problems in terms of regarding their emotional problems or psychological problems with these tools. So what about the study regarding diabetes quality of life? And again, we do have a quality of life study. This is an open-label prospective multi-center observational study where patients with type 2 diabetes, male and female between 18 and 65 with an HbA1c between 7 to 10% and uncontrolled on metformin or lifestyle modification for at least 3 months or are metformin resistant are screened and then started on sitagliptin and metformin, either plain or extended read, and are studied for 6 months. So the primary endpoint was diabetes quality of life assessment using diabetes quality of life 13 questionnaire up to 24 weeks. And the secondary endpoint was frequency of adverse event during the course of study follow-up, the frequency of serious adverse event, change from baseline in HbA1c and fasting blood sugar to the loss observation up to 24 weeks. So 504 patients or participants were screened, 240 were enrolled, and 188 were completed the study. So there were about 264 non-eligible, and you can see the reasons of exclusion. So the majority were due to either they were controlled on other therapy or their HbA1c was less than 7 or more than 10%. And then there are a few which were excluded due to safety risk or informed consent not given or age more than 65 years or type 1 diabetes. And here you can see those who are controlled other therapies, most of them were already on insulin. Then 35 patients were on other combination, 26 on other classes, 5 on different DP4 combination, and 12 on metformin. So what about demographics? So I think the male-female split is pretty much equal. Most of them were middle education, so more than half had middle education, about 1/3 were graduate or above, and about 10% were uneducated. And again, most of them have middle income, so about nearly half have middle income, about 1/3 upper income, and around about 1 in 5 lower income. Majority has less dependent, so less than 3, and they were non-smoker, so about 80%. And here you can see the comorbidities, so about 31% of patients have comorbidities, and as expected, majority was either hypertension or dyslipidemia, and then there are a small number of people with ischemic heart disease, chronic kidney disease. So they were, the mean age was 46 years, mean BMI was 27, and the duration of type 2 diabetes was 2.41 years. So what's the primary outcome? And here you can see across all domains, across satisfaction, impact, and worry, you will see an average of 15% differences, or 15-point differences. So 7 or nearly 8 with satisfaction, nearly about 5 with impact, and 3 with worry. So you will see here the trend. So around about 15.24 point reduction, the baseline was 57, and it was 33 at the follow-up. So 23% reduction or improvement, 23% improvement in quality of life on patient who was started on metformin and sitagliptin. What about secondary outcomes? So overall, 21% of 240 enrolled patients reported any adverse events, majority in the first visit, 16%, and 11% or 12% in the second visit, and 7% in the third visit, but there was no serious adverse event reported. And here you can see, so as expected, it was a GI effect. So nausea, vomiting, diarrhea, flatulence, indigestion, abdominal discomfort. What you expect with the sitagliptin metformin combination, there were only very few hypoglycemic episodes, mostly in the first visit. So HbA1c here you can see, so you can see a 1.2% decrease in mean HbA1c, and 45 milligram per deciliter reduction in fasting plasma glucose. So here you can see from baseline of HbA 8.4, the HbA1c reduced to 7.2%, and the mean fasting plasma glucose from 162 to 114. And these 4 variables were mostly were strong predictor of quality of life. So gender, HbA1c, the higher the HbA1c, the worse the quality of life is expected, and the side effect like diarrhea and abdominal discomfort. So to conclude, there was a significant 15.24 mean point improvement in diabetes quality of life score. Minor adverse event were reported in 21%. There was no serious adverse event. HbA1c reduced by 1.2%, and fasting blood glucose sugar by 46 milligram per deciliter, and gender, HbA1c, diarrhea, and abdominal discomfort, a strong predictor of quality of life. And this study was published it was also published as a poster, but it was also published in BMC Endocrine series. So that's the article in the BMC Endocrine. And with that, thank you very much, and I'm open to any question.
Now, I want to hear some comments from the respected chairs. Sir.
Bismillahirrahmanirrahim. I could hardly see anything on this monitor because of light. So I would rely on what I remember. Thank you very much, Dr. Umar, for a very nice presentation. Quality of life. Whenever we talk about quality of life, we talk about life. When we live for quality. We work hard for quality of life. We study for quality of life. We do research to improve our quality of life. So quality of life in diabetes management means to improve the complications, to avoid complications. And to avoid complications, the basic principle is to control sugar. That's it. We are living in the era of SGLT2 inhibitors, GLP-1 analogs, and so on and so forth, new medications coming up. But what about this drug, this DPP-4 inhibitor, which is very less talked about these days? And if this can decrease HbA1c to 1.23%, as our research says, I think this will be one of the best medication to improve the quality of life. Let me share one more thing. What is the most common complication you feel you face in your clinics? This is the question from the audience. The most common complication of diabetes you face in your clinic. Pain is the most common complication. I'm doing a metabacity project which we started 4 years back, and almost 2,000 patients have been enrolled. And the most common complication we experienced in our study was diabetic peripheral neuropathic pain. 43% patients, they complain of pain. And if you relieve this pain, believe me, the quality of life will be improved. And we will talk about so many medications regarding this pain, so many newer medications rather, but believe me, to control this pain, you should control your sugar. You have to go to back to the ABC, and A is HbA1c. So to control the complications, to prevent the complications, you need to control sugar. And when you control sugar by this drug or anyone, definitely you are going to improve quality of life. Thank you very much.
Yes, ma'am.
Bismillahirrahmanirrahim. Like, it was a very nice talk, and you have explained the importance of quality of life as well as the study itself very nicely. What I want to say over here is that, like, as ADA has incorporated this quality of life being like taken up in the clinical practice, the reason behind this quality of life incorporation in the regular clinical practice is that quality of life, what we mean, like we have just done this quality of life 13, and it has 3 components. The worriness of the patient regarding what will happen next and how it will end up, the diabetes will end up in their lives. The most important is satisfaction. Afterwards, there is an impact, and third is the worriness. And what we feel during the study, 24 weeks is like a very short period. As we see the patients, they are in chronic disease and they suffer this disease for years. So, as you may have noticed, that the most improvement was shown in the satisfaction, which is expected in the 24 weeks of this trial. Then the improvement was in impact, but we have only 3 points improvement in the worriness, as it requires a longer period of a positive interaction with the physician to reduce the worry of the patient. Why we have a better HbA1c reduction within 24 weeks with this quality of life trial? As we know, normally we expect 0.7 to 0.8% decrease in HbA1c with only DPP-4 inhibitor. As metformin was already have maximum effect, they were taking all patients were taking metformin already. So the improvement was drug adherence following the lifestyle modification advice, just because the physician has asked 13 questions related to the physical, the mental health of that patient. So it has maintained a very nice interaction, and the patient like feels that he is like cared by the physician. Normally we don't ask about these things in our clinics, we just focus on the numbers. So this was the main take-home message, that we should ask about their worries, their satisfaction, how they have understood the disease, and how they think that this disease would impact their lives. So this was all about this study, and the quality of life questionnaire, which the Catch Pharma has has the QR code, is for all the physicians to download that and incorporate that within their normal clinical practice. Believe me, it takes very less time as we expect to just ask all these questions, but it has a great impact on the patient's quality of life. Thank you.
The house is open for the audience. Any question from the audience?
Bismillahirrahmanirrahim. It was a nice presentation by Professor Raja Saab. And Professor Mustafa Saab talked of the pain. And control of the pain has got a high weight, you know. The patient symptom control matters a lot. But you know, when the pain failure is there, sometimes you have to use multiple drugs to control the pain. But simultaneously, the other complications are already accruing, including the diabetic ulcers, weakness, or diabetic peripheral neuropathy, leading to the failure of the patient to walk its own feet. And I've seen patients, that those patients in whom the control of the pain is difficult, and you are requiring multiple drugs. The other complications like diabetic ulcers and gangrene and leading to the amputations are already there. And in my experience, the patient become bedbound with the poor control of the pain. Of course, this was certainly an offshoot of the poor glycemia control. So what I have experienced is that those patients which require multiple drugs for control of the pain, the other complications are already there, and the quality of the life remains poor. What is your experience, Dr. Umar?
And I think I agree with you. And I think what we also need to understand is that the pain perception is not only physical, but there is a psychological element to that as well, and there is a social element to that as well. And I think to treat pain, that's why not only we should be thinking about any objective diseases like neuropathies or say frozen shoulders or muscular aches and pains, but we also need to think about whether these people are depressed or not. So often they are actually depressed, and with that depression, the manifestation is actually that pain all across the body. And that's where those quality of life does help you as well, because you are looking at human beings are not only the physical creature, there is a whole emotion aspect to that as well. So, and that's one of the reasons. So I think one of the reasons that look at your neuropathic pain relief. Duloxetine is actually an antidepressant. Amitriptyline is actually an antidepressant. And part of the reason these medicines work is because they are also antidepressant as well. So you're absolutely right that we should be thinking about, these, if they are having a lot of pain, it's going to affect their quality of life, and then it's a two-way process. Not only that will affect their quality of life, but if they have got a poor quality of life, that will contribute to pain as well. And you have to break that cycle. But the thing actually is, and that's the important thing is, your eyes can only see which is there if you're aware of that. So if you're not aware of what exactly the quality of life of this particular person is, how will you find out? And that's where the questionnaires helps. I think the more important than that is that these questionnaires should be translated into Urdu and should be validated. Because only then, once it's validated, it will be relative to our population. I think I was doing some sort of basically study, and that was actually the education regarding children with type 1 diabetes. And there you have to be quite, a lot of us translated from the Western countries, but you have to think about, do I have to ask about the, say, alcohol or the sexual health in a 14, 15-year-old girl in the front of their parent? I think in our society, this might not be culturally appropriate. So that's why whenever we are going to think about translating them, you cannot simply translate everything there. You have to think about how you can make it culturally appropriate, and that's important. And I think that's why we need your contribution, especially the young people in the audience, because there's so much data and there's so much potential to publish those studies. There's nothing virtually in Pakistan regarding those domains.
Actually you're right. We have translated this quality of life questionnaire translated, validated, and piloted as well. So everything is there. Thank you.
I have a comment. Dr. Latif has very rightly mentioned. Again, I will go back to the basics. To control diabetic peripheral neuropathic pain, you have to control diabetes. Very simple. जो basic चीज़ होती है, let me just discuss one simple thing, one simple study which we were discussing few days back regarding control of hypertension. What do you think in the modern era is the most effective drug to control hypertension? Those who know the answer, please don't reply. काफी सारों को मैंने चुप लगा दी है. Which one is the most effective drug to control hypertension? Believe me, the study proved that recording blood pressure correctly is the most effective drug to control hypertension. Majority of us, we don't record blood pressure correctly, and we are tagged with hypertension, unfortunately.
And I think coming back sort of basically to that, people often ask me, what's the best diabetes drug? And I said, the best diabetes drug is what the person take.
Yes.
But you can't take a tablet, no matter how good everybody says, it's not going to work. And I think these are the things in terms of adherence, in terms of the impact on quality of life that we are lacking, and we should be thinking more about them. Because all of you knew about diabetes, I'm quite sure about it. But we all knew somebody's practice is there. And it's the way that they deal with that patient is that the emotion side of things, it's that empathy which is very, very important.
Sir, I have one question. What do you think vitamin and minerals, they have role in improving the quality of life in diabetic patients?
So in March, I was actually part of SAFES in Dubai about hidden hunger. And to be honest, I didn't know about hidden hunger till they asked me to give a presentation. So the hidden hunger is actually the presence of minerals and vitamin deficiency in population, and it's something which is quite common not only in the developing countries but in the Western society as well, and there is a number of reasons behind that. Our diet is very monotonous now. The crop rotation is not there, so there are so many factors which give rise to the hidden hunger concept. And the 3 or 4 big vitamins are vitamin A, vitamin D, iron, and zinc. But I normally tell my patients, I'm actually not a big fan of multivitamins, to be honest, partly because for a couple of reasons. A, I was trained in UK, and in UK, you were asked not to prescribe multivitamins. B, I often find with your patients, they might not take a statin tablet, they might not take a blood pressure tablet, but they will always take that targeted tablet. And I normally tell them, if vitamins are so good, then Allah would have made multivitamins trees. So I think we should, number A, try to ask them to vary their diet and get their diet from or multivitamins source from food, which is the right way. This is what I believe, to be honest. Not only medically, but maybe from a religious point of view as well. But having said that, sometimes with age specifically, so my mom is 85-year-old, 86-year-old, and I knew no matter how much I try, her diet is very limited. A lot of she's going to have porridge and bread and nothing else. And I think in certain people, replacing the multivitamins does help. So many women in our society, I always found them iron deficient. And some of them have got celiac disease, but it's just purely sometimes about that culture aspect of giving, say, meat to the men of the house or to the children, and the woman not having them, and then heavy periods, so many other factors, and they are iron deficient. So I think we should be thinking about that. So it's also the individual approach.
मैंने बता दी थी गुड़िया, आपने मिस कर दी. You missed it, and once you missed it, everything's gone.
Assalamu alaikum. My name is Dr. Nikhil Samal. I'm from Ayub Medical College, and I'm assistant professor of medicine basically. But currently, I am running a diabetic foot clinic here, there at IU Teaching Hospital. That is at a very preliminary level, you can understand. So recently, 3 months back, I came across this patient, and he is around 30 years old and married with diabetes. He was basically referred by a cardiac surgeon to me, and he had a angiography before that. And he came with peripheral neuropathy and painful peripheral neuropathy. So initially, his angiography was already done, and that was totally normal. And his sugars were not well controlled, but that was okay. His HbA1c was around 8, 8.5, like that. So initially, this is what we thought, and we try to control his blood sugars and his other risk factors. But after taking a detailed history, I came to know that he lost almost 10 to 15 kg weight in the last 3 months just because of this pain, because he cannot sleep at night, not at all. So I was in consultation with an endocrinologist, and he already have seen like many other physicians, and all of them prescribe like duloxetine, pregabalin, and everything. So by the time he presented to me, he was already on 3 drugs. That was amitriptyline, duloxetine, and pregabalin. Pregabalin at the maximum dose. But still his pain was not relieved. So I had to admit that patient just because of his poor quality of life. So I can observe him and I can see what is going on. So even after this admission, we could not really find out why he is in such a pain. And all we could do was just improve his sleep to no sleep at all, to just 2 to 3 hours per night. So still that was not good. And then even later on, after discussing with everybody, we could not find really the cause. So the patient was still happy because now he could sleep 2 hours with all these medication and all that. And then I decided to send this patient to one of my dermatologist friend, and I discussed the case with her because we were really like we could not really find a solution for him. And that turned out to be a fungal infection involving all his toes. And when he was put on the an oral antifungal, so he improved almost in 2 to 3 weeks. And he is still on antifungal on and off. So I just want to know your experience regarding this, that how frequently you see patient with fungal infection who has this much severe painful neuropathy, because now his pain has improved. He is just now on pregabalin and his blood sugars are really controlled. Now I have even decreased his dose of insulin. So I just want to know your experience. Thank you.
Not about looking at the fungal infection and that was the cause. The lesson is sometimes if the pain is out of proportion, and it's the same thing with if someone is been newly diagnosed with type 2 diabetes and they have got a heavy protein urea, it just make me think, is there anything else going on? And I so often ask the nephrologist about maybe at that time doing a renal biopsy, and they found out that nephropathy is actually due to another condition. So it's the same thing. If the pain is beyond what you expect, sometimes you need to think about, is there anything else going on? I mean, just before coming for this meeting, I saw someone whose diabetes, I mean, her HbA1c was 6.1%, but the pain is severe. So you need to think about whether they have Hep B, Hep C, might be having cancer, can give rise to peripheral neuropathies as well. So that's quite important. And again, I mean, not related to diabetes, but I do have few families with autoimmune polyendocrine syndrome type 1, and they can have chronic mucocutaneous candidiasis. And some of them cannot eat, and because of that, they will have their weight loss. So you have to give them antifungal so that their oral or esophageal candidiasis is improved, and then they are able to eat. So the message is actually that sometimes you have to think beyond. I think sometimes it's so. Two things I always found it, a lot of, I would say, the healthcare physician think, oh, you have got this and that's causing. So one is thyroid. Someone have got thyroid, and a lot of people say, you have thyroid, this must be due to thyroid. And the TSH might be absolutely normal for the last 3 years. And the other thing is diabetes. So, I mean, there is individual variations. There is genetic potential as well. So that's why two people with diabetes might have two different complications. And there is so much that we don't know about that as well. But generally speaking, if it's well controlled and you cannot see anything, or you're giving too many tablets and nothing working, we need to think about, are we missing something? And that's where sometimes a second opinion helps. So often I send my patient with pain to pain clinic because I'm at loss of why they're having so much pain. So that's an important lesson.
Thank you very much, sir. It was a very nice interactive discussion. I am very much thankful for the chairs for accompanying this discussion. Once again, thank you very much also for the audience.